So good morning, everyone. It's an awfully big room, and people seem to be dispersed quite generously throughout. So if it would be easier, please feel free to come sit at one of the speaker tables as they're labeled. My name is Yagoda. I'm the Director of Primary Care at CommUnityCare, which is an FQHC here in Austin, Texas, where we serve almost 100,000 patients, over 50% of whom are underserved. And I'm here with my colleagues, Rich and Sarah, who will introduce themselves once the mics, are the mics turned on up on the table back there? And we're going to speak briefly about the collaborative we put together to offer medication-assisted treatment within our community. And we'll speak briefly about what the different facets of that have been. But then hopefully we'll open it up for a dialogue back and forth so we can discuss what the experience has been trying to stand up a program of this sort. And I also want to introduce John Wynn. John, if you want to come up too, that'd be fine as well. Or who is with Integral Care, who's one of the collaborators up here, for this pilot as well. So do you all want to introduce yourselves real quickly?
Sure. Hello. My name is Rich Bottner. I'm a physician assistant at Dulce Medical Center, which is our safety net hospital here in Austin.
I'm Sarah Cook. I do strategy and population health for the Community Care Collaborative, which is a partnership between the Seton Healthcare family and the Travis County Healthcare District, also known as Central Health. We were born a number of years ago to really knit together both the ambulatory and the hospital and specialty care sides for the indigent population that is the Travis County Healthcare District's responsible here, for whom we are responsible, excuse me. And the CCC has funded this medication-assisted treatment pilot. I think it's an 18-month pilot, and so we're pleased to be here as a sponsor and ensure that these patients in our care get these services.
So specifically, as we talk about this project, we want to highlight a couple of the unique features, and one of them is that this is an M80 program specifically set up for a safety net population. And that brings a number of unique qualities to it, which hopefully we'll be able to review. And it also, part of the uniqueness is that there are so many different partner organizations, principally standing the clinic up itself. So we have a primary care delivery system in community care, behavioral health delivery system, in all of which are tasked specifically with targeting the safety net community. And then a very unique funding opportunity through the CCC and Central Health that allows for some very creative and innovative development that may be somewhat unique for a safety net population, but it's offered us some really great opportunities to provide much needed services. So the impetus for this was the obvious, is that there is ample research out there. I just pulled out one slide because it's a dramatic slide, which shows that in the gray, as you see, the introduction of buprenorphine into a community in terms of opioid substitution, opioid replacement therapy, the dramatic decline of heroin overdoses. This is data out of France from a couple of years ago. The slide on the right will show data that came out of Baltimore that was published within 10 years, I believe. But this is a fairly busy slide, but I just wanted to state the obvious for everyone in the room. We've talked a lot. There's been great panel discussions and keynote speakers around specifically pain management and the use of treatment for opioid use disorders, but I wanted to specifically state the underlying impetus for all of this, which has not actually been stated so explicitly, is that it does save lives, and there's data to support that it saves lives. There are three, at this point, options for FDA-approved options for treatment of opioid use disorders, being methadone, buprenorphine, and naltrexone. We're going to focus on buprenorphine because that's what we're using in our clinic, and and here stated are some of the benefits of buprenorphine over methadone and over naltrexone, and which is what drove us to select buprenorphine for use in our clinic specifically. It's lower risk of physical dependence, milder withdrawal symptoms, less likely to cause overdose, and it can be prescribed by a physician provider, specifically actually a primary care provider within our clinics. It also has advantages over naltrexone that you don't have to have already gone through detox. So whether it's transition of patients from the hospital or from other acute harm reduction programs, we can actually get them onto therapy rather quickly. The concept of M80 as opposed to OBOT, the OBOT programs, or some of the other models is that the medication, the pharmacologic approach is tied very tightly to the behavioral health counseling. So there's a full wraparound service treating in a whole, what we call a whole person approach. It uses a chronic disease model. And with MET, we see decreases in opioid use, opioid-related overdoses, criminal activity, infectious disease transmission, and all-cause mortality. Just put together a couple of, there's much more data, but I put together a couple of the references on the side if you want to keep that. Also increases social functioning, retention, and care. And then amongst our pregnant patients, improves outcomes for newborns and reduces length of stay and NAS symptoms. This was data that came from the NIH. The last point down there is that amongst states and the District of Columbia, 96% had opioid abuse and dependence rates higher than the buprenorphine treatment capacity. And within our Travis County district, we recognize this as we fit that character. And so all of this information combined together is what drove us to start the program. Yes?
Could you repeat what you just said, your last statement about realizing, because I can't see the studies, but you realize that you fit Travis County fits into this?
Travis County fits into this cohort of folks where the opioid abuse and dependence rates far exceed the treatment capacity. Yeah. Sorry, sometimes I speak too quickly, and I'll try and slow down. There are a number of different M80 models that we looked into as we were trying to develop what best suited our purposes. Some of them are practice-based models, so OBOT, as we've spoken about. There are a number of published models that, and I put up over here the publication that AHRQ put out, which goes into some detail about a bunch of the different models. But OBOT, there are combo HIV MAT programs. There's one that actually combines HIV Hep C and MAT, and a prenatal MAT program. We are driving a little bit more from a systems-based model, which will incorporate a couple of these aspects, but the hub and spoke is one that we aspire to. We're not yet at that place, but we'll speak to that a little bit. Medicaid Health Homes, Project ECHO, collaborative opioid prescribing. A nurse care manager model is something that we adapted our program off to, and I'll talk a little bit about that. And then there are other system models that include ED initiation, and inpatient initiation of MAT, which Rich will speak to a little bit. So ours is what I would consider to be a modified collaborative care model. The collaborative care model was first published by Alfred et al. In the Archives of Internal Medicine. The principle is that it's really team-based care at its best. The patients we look at, we strive to engage are those who are MAP enrolled and eligible. For those who are not from Travis County, MAP is our medical assistance program, which is, I'm gonna be super brief, and Sarah, if you want to flesh this out, you can at a later time. But basically, it's the funding source that state garnered funds through taxes is able to provide for a select group, which is a very large group of those who are uninsured within our county. We're restricting this to the adults, and we aim to principally try and treat those who are stably housed, because in this pilot program, and I have to step back and actually say that this is a pilot program. We are in an 18-month pilot where we're test driving everything together. And in this pilot, we've selected to try and focus on the stably housed, but I will give an example of how that we had to actually flex our system from a harm reduction perspective. And then, of course, you have to have a primary, secondary diagnosis of an opioid use disorders. Some conditions that other models have used as eligibility criteria, we sort of set as conditions requiring consultation. So basically, was the team sufficiently equipped to deal with folks who have active alcohol or benzo or other substance use disorders? allergies to buprenorphine obviously would have been exclusion criteria, but previously unsuccessful buprenorphine naloxone treatments might be a condition to review for adequacy. Seizure disorders, Hep C, B, and HIV, unsupported recovery environment, and breastfeeding are all things that would be conditional precautions in terms of immediate inductions, but everyone else could be started immediately. The care team is a pretty diverse group, some of whom are in this clinic, but we've sent them out to other learning opportunities. So hopefully I can speak well enough for their experience, but we have a social worker who is really the glue. In the nurse care manager model, it is a nurse who tends to be the glue, and they've done this very well in Massachusetts. The BMC and other FQHCs in Massachusetts have stood up some really great examples of how this system works well. In our system, we've adapted it a little bit so that it's a social worker who's really doing the intake and screening and serves as the glue that keeps everything together. This is really the point person for that the patients will identify as the principal member within the team with whom they engage. The RN, social work, and MA are responsible for the intake, data collection, and urine drug screens. The physician does exam, assessment, diagnosis, and is the prescriber. And then the RN has additional responsibilities of observing and overseeing really the induction, providing patient education, the monitoring, and pharmacy coordination. And then social work is maintaining a registry and outreaching to our community-based organization partners. And then we have a very robust team provided through Integral Care who does the wraparound behavioral support and social supports. This is just data I'm going to spend only a brief moment on, but just that the collaborative care model is a good model, and that we have a 50% successful treatment rate, which again, going back to some of the data that Dr. Waller spoke about, 50% seems in a lot of our data-driven minds to be a fairly low number, but that's a lot of lives saved. Hub and spokes. This is our aspiration at this point. Speaking to the themes that have come up, and I'm sorry this is coming out hard to read, please don't spend any time trying to read that language because we've gone over it already. But the idea of providing a center of expertise to really manage those most complex patients while creating, building more towards what we call the patient-centered medical home model, where we can provide care where the patients are themselves in the satellite or spoke sites, is what we aspire to at this point. Right now we're building up the hub, but we are also training up additional providers to serve as those spoke sites out in the community. We've driven up a workflow that's, again, hard to see, but is a reflexive response for the team in terms of when you get abnormal drug responses, so that we have a built-in within our organizations, a very robust hepatitis C treatment plan, an HIV specialty center. Our women's health and OB services are tightly involved for patients who might need additional women's health treatments, and we feed back and forth for intakes that they might get for new prenatals who have substance use disorders. We can very quickly engage them in the necessary medication-assisted treatment. And data collection, the final point being, within this collaboration, we will then feed a lot of our data back to the Dell Medical School, who will help us process the information for internal process improvement, but also if this new model proves a compelling one, to publish and become part of the greater conversation that's going on nationwide, particularly within the safety net communities. Our next steps are building the robust partnerships that Rich will speak to about the hospital system and inpatient inductions and transitions from the inpatient to outpatient services. Building a strong network with the Austin Public Health Service, the Department of Corrections, harm reduction, other community outreach services. The hub and spoke that I spoke to, and some of the data processing. Here, for anyone who may be from our community, if you want to make referrals, Sarah Young and all her information is over there. You can come speak to me afterwards. You can take a photo of this if you do have patients that you want to send over to us, but we're ready, willing, and able to help serve in what capacity we can. Let me hand it over to Rich then.
Good morning. Curious by a show of hands, how many are from Austin? Almost everybody, all right. And anybody work in a hospital setting, hospitalist, social worker in the hospital? Handful, all right, excellent. And so what I wanted to talk about this morning is something that we are doing at Dulce Medical Center here in Austin that we're pretty excited about, and from what we can tell is pretty unique and innovative. I will also add, like Dr. Yagoda did, that we are even more of a pilot than Dr. Yagoda's clinic. The M80 clinic here has several dozen patients, I believe, at this point. We have 0. We are in startup mode. We are getting ready for our Shark Tank presentation here pretty soon. That was a joke. So we do not have patients yet. We are in the process currently of going through what our process map looks like and getting all of our community partners engaged. Dulce Medical Center is the safety net hospital here in Austin for those who are not from town. About 50% of our patients are part of that MAP population that Dr. Yagoda spoke about earlier. And the remaining 50%, about half of those are Medicare or Medicaid. We have about 20% that are what you would consider private pay patients. So we are the safety net hospital. This particular hospital opened this past May. It's brand new, it's beautiful. If you've never been down and you'd like a tour sometime, let me know, I'm happy to do that. But we were University Medical Center Brackenridge, which was a part of this community for almost a century prior to building the new hospital. And the new hospital is part of the collaboration with Dell Medical School, really becoming leaders and innovators in healthcare. And so this program is one of the many things that we're doing that I think is pretty unique and exciting. And so a couple of things just to kind of think about here is, so why initiate MAT in the hospital setting? If you had asked me 4 months ago if I would be doing this, I would have said absolutely not. I really knew nothing about this 4 months ago. I think most hospitalists currently feel how I felt 4 months ago, which is our main job as a hospitalist when a patient comes into the hospital is to get them through withdrawal and then monitor them while they're there. And then when they discharge, we have often felt that there's not a large role for us in terms of setting them up to have resolution of their addiction habits. And then, of course, as we know, the cycle of addiction, most of those patients will go and use again and end up back in the hospital for reasons that are often associated with the underlying addiction. And so what we are really trying to do is to break that. And so about 4 months ago, I got an email through the Society of Hospital Medicine that the state of California had given funding to a program called Project Shout. And Project Shout was designed specifically for hospitalists on how do we try and impact the opioid epidemic from a hospital standpoint. And what I've really taken away so far from this meeting is that we're a very, very, very small part of this very large pie, right? We're not really on the prevention side, and we're in the treatment side, but we're one little slice. We're one referral source for Dr. Yagoda's clinic as an example of the many referral sources that are out there. But that we still have a role in this, and that's what Project Shout is trying to share across the country. And so I started participating in some of those webinars, and I really started to gain an appreciation for not only how serious the opioid epidemic was, which I think I already had a pretty good appreciation for, but what I could do as a hospitalist to have an impact in this. And so I emailed our executive leaders and I said, is this something that we want to take on as an institution? Do we want to look at this? And the loud answer was yes, we do. And so this was probably back in the beginning of November when we started working on this. And what was really neat about this was sent a few emails out to Dr. Yagoda and his team and a few others throughout all the stakeholders that are on this slide here. And we put a meeting together in less than 2 weeks to talk about how we can make this happen. Now, I've been in healthcare now for 6 years. I've never put a meeting together in less than 2 weeks with all these different stakeholders from all these different organizations. So it was really neat to see that there was a lot of interest in this project. So why do we want to do this in our hospital population? Well, for the most part, or for several reasons. One is that patients who have an opioid addiction and they leave the hospital and we haven't really provided them with adequate resources, their readmission rates are significantly higher than patients who do not. And that's really important for anyone that works in hospital. Readmissions is something, especially as a safety net hospital, that we are constantly trying to assess and reassess. I'm on both the Del Med and the Seton readmissions committees, and we're struggling with this like any safety net hospital. And so we know that this population is particularly challenging when it comes to readmissions. We also know that this population is very challenging when they're in the hospital, and they often have prolonged hospital stays. And so for several weeks they're in the hospital, we get them through withdrawal, and now we have behavior that we're trying to modify, that we're trying to control while they're in the hospital. And I think there's a lot of frustration on the part of the hospital teams that we don't really have a lot to offer these patients. We're not taught how to deal with this in school, and in our hospital we have social workers and we have a psychiatry team, but they're really not equipped or designed to deal with this. They're dealing with more acute issues, not issues that for the most part are considered secondary diagnoses to the primary reason for hospitalization. So this is, again, it's really, really important. We've talked about our relapse rates and recovery rates in terms of being able to link these patients to outpatient therapies when they leave the hospital. There are about 3 or 4 programs that we could find in the literature that are similar to this, the most common one being Boston Medical Center. And what makes our program, I think, even more unique than theirs is that in all their data, for the most part, it was the addiction service, and most of them had an addiction service in the hospital. It was the same providers on that service in the hospital who would also follow the patient in the community when they discharged. And so what's really exciting about this is the providers who are seeing these patients in the hospital are not the providers that are going to be seeing them in the community at the Dove Springs Clinic with Dr. Yagoda and the Integral Care teams. And so this creates, another layer of complexity that we're excited to kind of solve and share in the literature moving forward. So barriers to MAT in the hospital. So one is patient misconception. We have a lot of patients who, for one, are not interested in therapy, and so that is a problem in and of itself. But we also have patients who have heard about buprenorphine, but they're not really sure about it, and they're concerned that if they start taking buprenorphine that they're just exchanging one habit for another. And so there's a stigma amongst our patients, of course our providers as well, but there's an educational piece that has to happen with our patients. There's lack of clinical experience. When I started going down this path in November, the response I had from my colleagues in our department, we have about 30 attending physicians in internal medicine, about 60 residents, and the response that I got was, sounds great, but I don't know anything about this. If you want to talk to me about opioid withdrawal, that's fine, but now you're talking about buprenorphine. I've heard about it. Isn't that Suboxone's buprenorphine? That's the only kind that's out there, right? I've never done this before. A lot of apprehension about getting involved in a program like this because of lack of experience. There's certainly a stigma, and so while my hospital executives were very excited to say yes to this, as I kind of went down one rung on the leadership ladder and started talking with some of our nursing directors, for example, there was a lot of apprehension around this, primarily because of the stigma around these patients. In the safety net hospital, and I think it really in the community as well, we have created a stigma around these patients that, this is a patient who uses, no matter what we do, they're going to leave the hospital and they're just going to use again. And what I am learning very quickly is that that's really not, number one, not good medical care, but number two, that's not the case, that's not the reality. Leadership engagement is often a barrier. I'm so thankful and happy that we have not had that issue at our hospital, but from reading the literature, that is a barrier for many of the programs that try to start. And I would say the biggest issue is linkage to outpatient care. I'm not the first person to think about doing this at Dulce Medical Center. Our psychiatry team has thought about this in the past. The barrier has always been that even if we set up a buprenorphine induction program in the hospital setting, there's no place for these patients to go when they discharge. And so it's great that now we've offered induction. We've actually set them up for probably even worse failure by not having any sort of community follow-up when they leave. That all changed in August with Dr. Yagoda's clinic. And so when I reached out to the community care folks and the integral care folks, and they mentioned that they had started this clinic, it was really a turning point in our ability to offer this service to our hospitalized patients, knowing that we could build a process with our outpatient partners so that when they discharge, we can do warm handoffs and we can facilitate these patients actually being seen in the community. The case for us in particular, Dulce Medical Center, We, again, have a very significant population like most safety net hospitals. We had a district-funded behavioral health social work team for the last 2.5 years. Unfortunately, the district funding ran out at the end of 2017, and so they're not part of our hospital anymore, which even supports our business case even more strongly to offer this internally. But the behavioral health social workers from 2015 to 2017, we had over 2,240 patients admitted to Dulce Medical Center who carried a diagnosis of substance use disorder. And then for a 1-year snapshot, 2016, 2017, we had 270 patients who carried a diagnosis of opioid use dependency, and 100 of those patients were deemed candidates for either methadone or buprenorphine induction. What's interesting about that data is those are only the patients who were screened by our behavioral health social workers. The behavioral health social workers, when they were part of the hospital, did not touch every patient. So what we're looking at is probably a much larger problem than even the data suggests. I think I have one more slide on here. Whoops. So just a couple more things here. So our team, our goal is primarily around buprenorphine induction for qualified patients. And qualified patient is essentially the same criteria that Dr. Yagoda showed a few minutes ago. We're really trying to mirror what community care and integral care are doing in the community so that we're aligned in terms of the types of patients that we're offering induction to. Our team is something I'm particularly proud of. We have an interprofessional, multidisciplinary team. We have about 50 individuals at the hospital that have gotten engaged in this project so far, ranging from our internal medicine residents, internal medicine attendings, our department chairs, our hospital leadership. We have pharmacy on board. We have social work on board. We have psychiatry on board. So we have a really excellent group of people who are really engaged and really interested in seeing this become a success. Our goal is around the induction, but our goal is also around stigma reduction. And so because of the Dell Med partnerships that we've been able to form, we've actually formed other partnerships throughout the institution at UT. So we've engaged the McCombs Business School to bring in business students to help us formulate our business case, our financial case for doing this on the inpatient side. We've partnered with the Moody College of Communications, which has a center of healthcare communication. And they're helping us with a stigma reduction education piece specifically for our residents, our attendings, and our nurses. And so this is really a multi-pronged approach. We also got a $5,000 grant from the American Academy of PAs, which is a grant through the NIH that's sponsored by the NIH to do this type of work. So we're really, really excited about it. So where we are in the build is we are in the process now. We have all of our buy-in. We are in the process of finalizing the criteria that we're going to use for our inductions. And really the last step in this process is working out exactly what the process map looks like, what the flow looks like from the time the patient comes into the hospital to the time that they leave the hospital and we do a warm handoff to Dr. Yagoda and the integral care team. Where we're going is we're really hoping to grow this. Our goal is that we have internal medicine, family medicine, engaged in this program as much as possible, that we are screening patients as much as possible, and that we're offering this to as many patients as we can, and that when our residents graduate, that they've completed the X-waiver course so that when they go into the community and they're practicing, that they are able to be effective prescribers of buprenorphine as well. So again, this is a unique thing that we're excited about. As I said earlier, I'm fully aware that we are a very small piece of the treatment pie. But I think it's really important. Like I said earlier, there are 4 examples that I could find, and I looked very hard, of programs like this that exist in the country. If successful, we'll be number 5. And there are many, 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 many safety net hospitals in this country. I think it's a really important referral source, and I'm hoping that we can bring best practices forward as we move on. Questions?
So is it FDA approved for use in youth as well? Is that the question?
That could be the question, sure.
I'm not sure yet. I could look back at that and get back to you. But it's not something that I've seen ample research on yet, but I know it is in, the first wave of research was all in the adults, but I know there is some work going on within the pediatric population, but I don't know about this. I can't.
What is your prescribing age, more or less?
We do 18 and older.
18 or
Yeah. Any other questions? Yeah.
Do you see potential to supplement the MAT with peer support recovery counseling services?
Yes. I wish Sarah were here. Our initial framework was just to make sure that we had a wraparound service within our organization partnership. But by all means, we are well aware of the advantages of extending further out into the community, outside the walls of the clinic, into peer support services. And it's something that we're actively working on in terms of our expansion. So absolutely, yeah. Yes?
In your exclusionary criteria, you basically said someone that can be stably out.
Oh yeah, let me speak.
I understand the reason for that, but I'm curious if you have any sense about how many of the folks who come in would otherwise be eligible will then become ineligible.
So it was initially listed. As one of the inclusion criteria because of the unique population set that we were trying to serve. In Texas, there's such a large uninsured population that we had to be somewhat frugal with the funding that we graciously had received from the CCC in order to cover the medications. And by the way, we were using generic buprenorphine and naloxone as opposed to Suboxone, which is more commonly used elsewhere because of that issue of the funding. And it's worked out just fine, by the way. But the idea had been that we want to minimize risk of diversion and lost medications in a homeless population that unfortunately suffers a lot of trauma and theft, much more than the other population. That being said, there were a number of cases that came before our team wherein there was a compelling reason to actually initiate treatment based on a harm reduction philosophy. And I'll give you one example. And one was a homeless couple who had been homeless for years and had set up a fairly stable tent camp and were working on a day-to-day basis tirelessly to support their habit. Now, were we to replace that habit with a team that had proved themselves to be very reliable and safe and with good insight, but just unfortunately were subject to the constraints of an addiction, we might actually be able to set them up for success on many, many fronts. So we chose to do that. And we've had to relax that criteria a bit on a case-by-case basis. But we're very much attending to both the balance of how do we sustain something that requires penny pinching to some extent within this population, while also strategically delivering services so that we can minimize care setbacks on a broader scale. Yeah, Adam.
So from a perspective of the family medicine clinic where I came to learn about this, most of the situations we deal with are people who have chronic pain and we suspect addiction. And I'm still trying to figure out where Suboxone fits in those cases. I wonder if other people in the room had some experience, but I unfortunately rarely deal with someone where addiction is the main problem. There's usually always chronic pain and addiction, and I don't quite understand how that would play a role for those folks.
So for those who might not have been able to hear it, the concern was that what role does buprenorphine and naloxone treatment play in patients who rarely fit in the one end of the spectrum where addiction is the only disorder that needs to be addressed, where also chronic pain comes into play. And I thought, I'll just speak briefly about this and others can chime in, but the presentations we've had over the last day and a half have done a tremendous job in highlighting just that rarely are these experiences just purely addiction, and that addiction, the neurobiological manifestation of psychiatric conditions, including addiction, manifest in true pain disorders. And so it behooves us, and I feel even more motivated than I did 2 days ago, behooves us to create more than what we've set up today, which is an MAT clinic for opioid use disorders. We really need to create not only the behavioral health wraparound service to deal with addiction, but we need to create a service that actually targets the pain condition itself. I'm not sufficiently skilled in addictionology to be able to speak to how specifically buprenorphine is used within a chronic pain addiction complex. So I might defer to other members of the community who could do that, but I will recognize from a leadership standpoint that this is something we're intent on building out, so that we can incorporate knowledge that was presented in cases like today and yesterday to provide the extension of services that the community actually demands, as opposed to what is being offered presently.
So in the future, there may be a chronic pain clinic where we could refer complex patients who we say, we don't really know if this is just pain or addiction and it's challenging. There'll be a place for those folks?
Sure, and I think there were some examples. I know Michael Sprints on the first day spoke to, he had an example of the clinic that he's running where it is just that, a combination of pain and addiction services or recovery services, because they do overlap so much.
I would say that one point on that is that buprenorphine is an exceptionally good pain medicine. And in fact, the two payers that I work with, we've actually made that first line for pain. If you're going to use an opioid, I mean, it's not first line anything, but if you have to use an opioid, buprenorphine is a significantly good pain medication. And the early wives' tale of it having a ceiling effect is not accurate. It actually gives increased, very dose-specific pain relief up to 20 milligrams per kilogram. So you can, there's nobody writes for that amount of buprenorphine, and its risk of overdose is zero as compared to other full agonist opioids, in that there's not one case of a person overdosing solo on buprenorphine that's an adult in the country. So
When combined with naltrexone or on its own?
naltrexone doesn't matter. That's the abuse deterrent. It does nothing clinically when they take it. Less than 0.001% is absorbed when you do it sublingually or buccally, and so it's only there as an abuse deterrent. And it has nothing to do with the actual care that they have. And also, you have transdermal buprenorphine, and that's a wonderful transition med because even if they don't want to stay on a patch, if they're on a full agonist opioid and they show up on Monday, you can put the patch on Monday and they won't have precipitated withdrawal because it's a 36-hour ramp up. And so that way they never have to stop their meds, they never have to detox in order to get to buprenorphine. You just start it, and as that one goes out of the system, this one slowly ramps up into the system. And there's literature on that. Howard Kornfeld out in California did a couple of good papers on that. And it is probably the best opioid to use in family medicine because it is the most forgiving, and it really works. And so I think that the role of buprenorphine is not just for addiction, but it could be for just primary pain. And there are the patch and which one is it? There's a buccal one, and I can't remember the brand name of it, the buprenorphine naloxone that's FDA approved only for pain. And Butrans is only FDA approved. The transdermal buprenorphine is FDA approved for pain. And you don't need a special license.
Do you mind if I ask one more question?
Yeah, please.
I read that if you start somebody on Suboxone or buprenorphine and they're on hydrocodone, that it can displace the drug and it can make the pain worse.
It just puts them into precipitated withdrawal, so it doesn't make the pain worse. And so think about it as a dimmer switch. If you have them on hydrocodone, which is ultimately morphine and Dilaudid, I mean that's what it gets metabolized into. That dimmer switch is turned up pretty bright, not all the way, but it's turned up pretty bright. And if I give them buprenorphine, which has a higher affinity and binds to the receptor much tighter, it displaces that, and the dimmer switch goes from 85% to 60% immediately. And that immediate shift in efficacy changes the patient's physiology to the point where they have precipitated withdrawal. Okay. So they'll have a withdrawal event. But the Butrans patch foregoes that because when you give it, it has such a slow ramp up that you're slowly replacing it, and so the dimmer switch slowly turns to 60, and you don't have that precipitated withdrawal. But if you have someone like in a hospital, the physiology is pretty clear. If I gave you Dilaudid and you're opioid naive prior to that, and I'm essentially resuscitated somebody with buprenorphine who was dying of a heroin overdose. Because, and they had never used opioids up until that point. And the Narcan, oddly enough, we had run out because we had 2 carfentanil overdoses. And we didn't have any in the emergency department. We had used over 100 milligrams of naltrexone in the last 2 hours. And so I gave them an IV dose of buprenorphine that woke them right up. Because it immediately rotated it to 60% and it displaced it. So it's great in that setting, but you can use it as a pain medicine and you can give more medicines over the top. It's got a unique physiology and it's worth reading about because it is unique, but at the same time it's super safe.
Thank you. Any other questions? Yeah.
Since I'm a peer support specialist in Texas, we have a healthcare clinic for our counselor, and we have a MAP program. One of the things I find that is, what I just need to know is how long do you treat the patient before you titrate them?
I can speak in general terms because the clinic's been open 6 months, and so we've not tried to titrate anything down. But the literature has seemed to suggest, and and Corey and I were just speaking about this, that attempts to try and wean people down before 2 years of maintenance therapy often ends up with worse outcomes than those who have had sufficient time to establish recovery, both physiologically and psychosocially, to be able to tolerate the wean off. But I don't know if, do you have any additional comments on that front? Or John, if you would like to contribute as
I
well.
think you said it well.
Okay.
I mean, that's
I mean, we basically, I also run another clinic that we basically and it really has to do with psychosocial factors. So stable housing, stable family, not being connected to the drug network, so financial stability, all those things take 2 to 3 years to establish if you want to do it. So it really is needing those factors. But if you taper off buprenorphine or methadone prior to being stable, it will be
So there is no fixed line we have per se, but we do hesitate to even consider it before 2 years.
That 2-year wait period, does that include like residential treatment, sober living, that intense level of support, or is it still outpatient?
So haven't gotten into the details of what, basically the way I think about it is the time from the last disordered opioid use. So if what we're trying to do is create stability, and that is stability biochemically in terms of the medication we're delivering, but also psychosocially in terms of the wraparound support we give. I think about, I set the time clock from the start of induction. The psychosocial support takes a long time to work out, but at least from the biochemical standpoint, that's the way I conceptualize it. Others may think differently.
And earlier you mentioned that if someone was breastfeeding, that would be a consult situation
Yeah.
for buprenorphine. Is it that buprenorphine is potentially dangerous to an infant, whereas methadone is not?
So the studies that have been done to date have mostly focused on methadone, but there is increasing literature coming out more recently around buprenorphine, and it's very favorable. A lot of it has to do with in the neonatal period for kids who are born with a neonatal abstinence syndrome or exposure in utero, you need to be very careful not to use naltrexone, and so we'll use buprenorphine alone rather than the co-formulated to avoid precipitating withdrawals that can happen either in utero or afterwards. And it's just a matter, more than anything, of making sure the full support in terms of the OB team, the pediatric team, the NICU, if that needs to be involved, is all set up before we just go ahead and do a quick start. Yeah. But we're very enthusiastic about using this from a harm reduction standpoint for pregnant women. Daniel.
Great presentation, and you guys just really hit it. That's exactly what I was talking about. As we've heard throughout this conference, it's not only opioid use disorder, but there's often this polypharmacy involved with multiple medications that they become addicted to. Part of it's being that trauma that leads to the opioids helping, but there's anxiety involved too. So benzos often become part of the issue, and yet you exclude that group from this whole treatment approach. So I'm wondering, is there any discussion about how do you then address those people that also have other substance use issues that need access to care?
Yeah, it's a great question, and I think the data that the folks from Dishes showed yesterday showed that actually the greatest impact in overdoses within the state is from benzodiazepines. The intention was not exclusionary from a conceptual standpoint, but mostly that the mix, within our MAT clinic, was mostly that the mix is fatal, or can be. And so we would want to very deliberately, as we introduce the program, particularly a program that is run using primary care providers, we'd want to be very shrewd about which clientele we start to access during this pilot period. With our eyes on that prize, which is that this is the very first step to a much larger expansion of treating addiction within the chronic disease model and having a multi-substance use treatment pathways for those that often will overlap. And so as we build this, I can say very excitedly that we're in the process of trying to actually hire addiction specialists to be able to increase our capacity and knowledge base within the organization to be able to take on those additional healthcare gaps that we know about but have not yet been able to identify. But thank you for bringing up that question. It's a very, very important acknowledgement that what we are treating here are opioid use disorders, and we get very tempted in medicine to isolate and discriminate and not allow conditions to cross over and to try. And this is the scientific method. It's reductive thinking. And to a certain degree, that is absolutely necessary. At the same time, no human follows those paths, and our behavior is very complex. And so while we can find best practices for specific disorders, we need to be able to integrate that within the whole person's idea of primary care delivery to encapsulate that overlap. Yeah, in the back.
First of all, thank you for this. These are awesome sounding programs. I have a question for each of you. For the MAT clinic, the OBOT, how are you addressing transportation issues surrounding patient appointments? And then for the hospital induction, is it just for patients admitted to the floor, or does it also include the emergency department?
So great questions, and I'll take the outpatient question. The transportation is a major issue that we, within CommUnityCare, Integral Care at Dell, and the CCC specifically, is very aware of and limits the type of care that we can deliver successfully. Within the MAT program, there is a built-in capacity for the social work team to actually provide access. And specifically, this was related to the provision of medication because we have the logistics are a little bit complicated in that we have our safety net pharmacy located at a different place from where actually we are doing our inductions. It's a short distance by car, but it is a distance. And so we built into our model that the social work team would be available if necessary to transport those patients to the pharmacy to pick up their medication to then come back, because we don't want folks undergoing, who are in the midst of a withdrawal to be riding I-35. So there is some build out specific to transportation that we have within our clinic. There are also other ideas that are being floated about how do we do this in general, not specific to only our clinic, but how do we provide transportation to the community at large who needs, where it's difficult to actually get to the hubs where care can be delivered. The corollary to this is, why are there hubs where care can be delivered? Why can't we go to where the patients are? But that's a whole other conversation that we can get to. And the CCC has been partnering with Dell and some other idea think tanks to try and use our what are those? Rideshare services. And I know that's been executed in a number of different places successfully, and so we're trying to build up a similar system that we might be able to use to provide means to our clinics.
Yeah, the millennial in me is very excited at the proliferation of ride sharing. There's actually a lot in the literature now about using ride share services for this patient population. So to answer your question about ER, our program, again, kind of echo what Dr. Yagoda said, we're in pilot mode, and so I think the most important thing in a pilot is to have some pretty strict criteria so you can track success. And so for the pilot phase, we will not be doing inductions in the emergency room. The patient has to be admitted to either the internal medicine or family medicine service, and we need to anticipate that they will be in the hospital for 72 hours. Now that might change as time goes on. I think there actually is probably more in the literature about doing inductions and offering some sort of M80 startup in the ER than there is on inpatient services, but that would require more stakeholder engagement than we probably have bandwidth for right now. It's been probably one of the top 5 most common questions that I get, and so it's on the radar, but for now it'll just be patients who are admitted to the hospital.
Other questions?
Thank you.
I've got something I want to say here. Hold on. So you were asking about transportation, and we talked earlier about Boston Medical Center. They came up with this great idea that has created a digital platform for people that need access to healthcare appointments or transportation from hospitals or from emergency rooms to access Uber and Lyft, and they have arrive within 20 minutes of their need. So instead of the Medicaid system here, which you have to schedule 3 days in advance, and they'll deliver you for your 1 o'clock appointment at 8 o'clock in the morning, and they'll pick you up at 4 o'clock in the afternoon. This is a way that you can actually access a ride that will come and get you within 20 minutes, deliver you to where you need to go. So for instance, if they are discharging you at 9 o'clock in the morning and your ride was coming at 4 for you, you can leave within 20 minutes and actually free up a bed that way. If you've got dialysis 3 times a week, you can make it to your dialysis appointments, and they've got all these kinds of things mapped out throughout the country, including Texas. If you've got somebody that's scheduled to see their hepatitis C expert at 11 o'clock and it's 11:02 and the front desk is starting to say, well, they're going to no-show, you can actually go online and see that they're stuck in traffic 5 minutes away and they're going to be arriving on time. So we're going to try to bring circulation in, but you can access this at any time. It requires the healthcare entity to contract and pay for the services, but it's a lot less to pay for a $15 Lyft ride than to pay for an ambulance going to and from the emergency room. Thank you very much.